Welcome to the monthly podcast presented by JAMA Health Forum. I'm Dr. John Ayanian, the director of the Institute for Healthcare Policy and Innovation at the University of Michigan and the editor of JAMA Health Forum.
And I'm Dr. Melinda Buntin, Bloomberg Distinguished Professor of Health Policy and Economics at Johns Hopkins University and the deputy editor of JAMA Health Forum.
JAMA Health Forum is a peer-reviewed, open-access online journal focused on health policy, healthcare systems, and population health, and one of 12 specialty journals in the JAMA network. Our podcast each month presents highlights of new content from the journal, including timely interviews with authors of research studies and commentaries. Follow us on jamahealthforum.com, on Apple Podcasts, or wherever you get your multimedia, and on jamanetworkaudio.com.
Our guest authors today are Drs. Katherine McCabe and Alister Martin. Dr. McCabe is an associate professor of political science at Rutgers University. Her research focuses on political psychology, communication, and behavior in American politics. Dr. Martin is an emergency medicine physician and assistant professor at the Massachusetts General Hospital Center for Social Justice and Health Equity at Harvard Medical School and founder of Vote ER, which offers patients who are unregistered voters the opportunity to register to vote. They are the lead author and senior author of a new study in JAMA Health Forum titled Healthcare-Based Voter Registration, a New Venue to Increase Voter Participation. Welcome to the both of you.
Thanks for having us.
Thank you for having us.
Alister, I wonder if you could start out by telling us about the genesis of Vote ER and of your research collaboration with Dr. McCabe.
Yeah, some of the listeners might have a question in the back of their mind, which is how the heck did an ER physician get involved with voting? And it all started for me when I was a third-year emergency medicine resident at Boston Children's Hospital. It was a sort of slow night in the emergency department on Friday night. Around 11 o'clock, a young woman came in with her two children, and she recounted a story to me. She said, "Doc, I've unfortunately gotten into an abusive situation with the father of my kids. And about 6 or 7 months ago, I decided to leave that situation, which was unsafe for the kids and I. And I came to the only place that I knew that I had family, and that was here in Boston. But over the course of the last couple of days, because of my aunt's untreated mental health issue here in Boston, she kicked me and the kids out. And over the course of the last couple nights, we've been sleeping in the car. And tonight, we were going to do the same exact thing. But I looked back and I saw my little 3-year-old and heard his teeth chattering. It's about 4 degrees that night. And I knew there was no way that I was going to do that to him again tonight. So I came here. Can you help me? And so I did what any good, self-respecting emergency physician would do. I called social work. And so I called the social worker. And the social worker shared with me that, yes, of course, there's definitely a way that we can help this patient as long as they provide proof of residence, that they are residents in the state of Massachusetts because of a state-based program. So I go back to the patient. Unfortunately, the patient was not a Massachusetts resident because, as she shared with me, she had just moved to the state. So I called the social worker back. I said, we've got to do something. Unfortunately, the patient is not a resident. The social worker said, well, there's only one other thing that we can do. And I said, what's that? And they said, we can register her to vote. Her voter registration would count as proof of residence in the state of Massachusetts. So I went back, I talked to the patient, and I asked probably at that point the strangest question I'd ever asked for me as a resident, which was, do you want to register to vote? And the patient looked at me and she proclaimed, she said to me something I'll never forget. I didn't know I could. No one has ever asked me that before. And that for me was really what triggered this work. We were able to get her registered to vote, get her into transitional housing. And I began to learn that she wasn't alone. There's over 72 million people in this country who are unregistered but eligible to vote. And that is the group of people that Vote ER really caters to try to get those folks in the front door and register to vote, many of whom for the first time. We're proud to say that we have over 700 hospitals now helping patients register to vote and over 50,000 clinicians using our Vote ER badges and lanyards to help their patients vote like their health depends on it.
Thanks for that introduction. And Katherine, you're a political scientist, and so you were drawn to work with Dr. Martin. Tell us about the data and the outcomes that you were studying in your article in JAMA Health Forum.
Yeah, so I think with the Vote ER program, the program has the opportunity to engage a really wide range of individuals, and potentially individuals that are being contacted in ways that are outside of how traditional campaigns might reach voters. So Vote ER had this potential to engage populations that are otherwise underrepresented in political participation and underrepresented in the political system more broadly. But we wanted to kind of test this and see the extent to which that bears out. And so what we did was we compared the demographics and the composition of people who were contacted through Vote ER in the program that Dr. Martin described, and compare that population to populations of the general public of the U.S. as measured through two major public surveys that are regularly conducted around the time of elections in the United States, the American National Election Study and the Cooperative Election Study. In both of those surveys, people are asked if they have been contacted by a political campaign or some other group about their voting decisions and about getting out to vote. So across these three very different forms of contact, Vote ER's contact with people in healthcare-based settings, as well as these populations in survey data who have indicated that they have been contacted by campaigns, we can see if Vote ER is reaching a population that's distinct from those who are reached by traditional campaign contact. And so what we find is, in fact, that the Vote ER contact is reaching a substantially younger population than is typical of the broader U.S. voting public or those specifically who report contact from traditional campaign outreach. So about 40% of those who were contacted by Vote ER leading up to the 2020 election were part of the 18 to 29-year-old demographic, whereas in traditional forms of campaign contact, you see numbers less than half of that as a proportion of those who are contacted. Similarly, we find that those who are contacted by Vote ER tend to be less likely to identify as white in terms of their race and ethnicity relative to these other survey-based populations. And we also find particularly that Vote ER has a higher representation of those who are measured to be Asian in terms of their race and ethnicity as potential voters, which is a racial and ethnicity group that tends to historically be underrepresented in politics and political participation.
And just to follow through, what did you find in terms of people actually voting in the election that you were studying?
Yeah, so one concern that we might have is that the types of people that Vote ER is reaching in healthcare-based settings might be people that were already going to vote anyway. So what we did was we looked at the vote history of those who Vote ER contacted and compared it to the voter turnout rates of those who were in the survey data. And what we found is that based on 2016 voting history, so 4 years prior to the study that we had, those that Vote ER contacted in 2020, leading up to the 2020 election, tended to have a lower baseline voting propensity. So they tended to be less likely to vote in 2016 relative to those in the survey data. However, at the same time, they showed greater gains in voter turnout in 2020 relative to that survey. So we found that not everyone who Vote ER contacted ended up voting, but more than 3/4 did in 2020, which represents a higher amount of gain in voter turnout relative to those in our survey comparison data.
Great. Alister, can you tell us what you think the implications are of this study for both policymakers and for clinicians?
It's a great question. Look, let's come back to the number that I mentioned up at the beginning. In this country, there are over 72 million Americans who are not registered to vote, but who are eligible to vote. That is the population of the country of France that is not participating in elections. I want folks to think about what some of the margins of victory were in some of our last couple of presidential election cycles. We're talking about numbers in the thousands, 10,000 to 20,000 to 30,000. We have 72 million Americans who are sitting on the sidelines. And when you look at the demographics of those folks, they tend to be younger, they tend to be more diverse, and by definition, they tend to be either never voters or unlikely voters. Well, who does Vote ER help the most? Based on the data that we found in this study of our 2020 election results, it helps those exact groups, right? These three groups: younger voters, more diverse voters, and voters who are more likely to be defined as less likely or unlikely or low propensity voters. These are the three groups that seem to be most uniquely impacted by the intervention, suggesting that healthcare-based voter registration is uniquely able and uniquely equipped to help bring these folks who are oftentimes on the margins, not just of our healthcare system, but on the margins of our democracy, in to have a seat at the table to help decide what some of the policies will be from a healthcare perspective that govern the way that we as clinicians take care of them.
With all of the clinicians and different healthcare institutions and emergency departments involved now with this project, are there places where you have to have different methods of registering people to vote? It sounds like in Massachusetts, you as a healthcare professional or the social worker could hand someone a voter registration. How does that work in other places where you have operations?
First, let's come back to our data. We have over 700 clinical sites participating in Vote ER right now. That's all 50 states plus DC. So we've gotten really, really good at trying to help hospitals, medical schools, clinics understand what's possible in their localities. And the good news is that at its core, what Vote ER is doing is helping patients register themselves to vote. There aren't any physicians walking around waiting rooms with clipboards. There aren't any mandatory voter registration check-ins. All of these are optional, non-interruptive, and for the most part, really straightforward reminders and nudges to patients about the importance of registering to vote. One of the most impactful things that we've seen across the country, actually, to make this work of healthcare-based voter registration really advance to the next level is our work coordinating with state governments. Back in 2022, we were able to work with Governor Charlie Baker to sign the first Civic Health Month proclamation in this nation. Civic Health Month is a month dedicated to the idea of healthcare-based voter registration, and it's celebrated every August. We launched it back in 2020, and Governor Charlie Baker, Republican governor, was the first governor to sign that proclamation announcing Civic Health Month as a state holiday. And New Jersey's Governor Phil Murphy was able to do that last year. And we've got a big push this year to have a couple of other governors sign on and make it easy for hospitals and clinics to do this healthcare-based voter registration intervention.
Thanks for sharing these insights from your very novel and important study. Alister and Katherine, at the end of our podcast interviews, we like to ask a couple questions of our guest authors. And Katherine, I'll pose the first question to you. What's the best advice you've been given about your career, particularly for developing policy-relevant work, such as your study in JAMA Health Forum on voter registration?
I think for researchers, it can be difficult to balance trying to tackle questions that you are able to test and answer, that are easy to test and answer, versus those that are important. And those don't always line up together. And I think in seeking policy relevant work, those often tend to be harder questions that are nonetheless important to address. And so in reflecting on figuring out which questions to pursue, I think the best advice I've received is to always front and center the question of so what? What is the impact of your research? And as you think through that impact, try to communicate it in a way that if you're explaining it to someone in your field, if you're explaining it to someone outside of the academy, if you're explaining it to practitioners, if you're explaining it to consumers or patients or voters, that you're able to craft a message and the implications of your findings that really resonate with each of those groups. And if you can do that, that probably means that whatever you find, if it's expected or unexpected, you'll at least learn something that will connect with people and have some type of impact on policy. And no single study may necessarily provide the conclusive or definitive answer on a particular policy, but it can at least contribute to some element of the question from which other studies can build upon it and provide a more cohesive answer to these difficult problems.
Great. Thank you. And Alister, I'll ask you, what do you think is the biggest change we'll see over the next 5 years related to health policy?
Well, if I had my own magic wand and could wave it across the land, I would say that the rise of the civic health movement, this idea that our physical health is actually determined to a large extent by our civic health, how much we're participating in elections, how engaged we are in shaping our democracy. And I think you don't have to look any further than the American Medical Association. The AMA just a year and a half ago sent out a new declaration acknowledging voting as a social determinant of health. This is the first time that the AMA has ever acknowledged voting as something that has anything to do with patients' health outcomes. And so this declaration, this acknowledgement of voting as a social determinant of health, is just one example of how traditional healthcare institutions and organizations are beginning to recognize the importance of healthcare-based voter registration and civic engagement.
Alister, for clinicians in our audience, if they would like to bring their hospital or medical group to collaborate with VoteER, how might they learn more about making that connection?
There are a couple of ways that clinicians, hospital administrators, and educators can get involved. Number one, you can get your own free Healthy Democracy Kit, which is a lanyard and badge. They will arrive in 2 or 3 weeks. Hospitals and medical schools can get involved as Civic Health Month partners to celebrate with us in August. And medical students, we have a once-a-year competition called the Healthy Democracy Campaign, which has over 120 medical schools competing against each other to see who can register the most voters. You can go to voter.org/join, VOT-ER.org/join.
Well, on that note, we'd like to thank our guest authors, Dr. Katherine McCabe of Rutgers University and Dr. Alister Martin of Harvard Medical School. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.